Hello, this is Dr. Bhomik. Welcome to my YouTube channel. And this channel is used mainly for educational purpose, and all the lectures are designed for the pediatric resident, medical student, and also some of the cases and some of the topics designed for pediatric endocrine fellows, even endocrinologists, and those who are interested in pediatrics endocrine, like endocrine nurse practitioner. Today, I am going to present a case which will be, I believe, extremely interesting to you, and many of you probably have not seen one. I am going to present a case of infant who born with ambiguous genitalia. I was consulted about this case, and which is not uncommon that one of the common consult is ambiguous genitalia. So I thought that this is going to be one of those varieties like CAAs and so forth, but my resident told me that Dr. Bhavik, this patient not only has ambiguous genitalia, but also has presence of testicle on the both side. So I thought that's going to be a little bit more interesting. However, as I go through the consult, and I am going to present the case as I go through the consult, and I believe this will be very interesting for anybody who is listening to my channel. So case is an infant with 46XX. I'm given a little bit more specific now. 46XX karyotype and ambiguous genitalia. Just a little background. I'm ex-professor of pediatrics and chief of the division of pediatric endocrinology, University of South Alabama College of Medicine. I was also spent a lot of time in United States teaching hospital in Air Force and retired colonel. So without further ado, let's go forward and see the case we are discussing. So this was a term baby, appropriate for gestational age, very good Apgar score, and born with abnormal or ambiguous genitalia. This is the second pregnancy. The mother's first pregnancy was a non-identical twin. So mother had a non-identical twin in the first pregnancy, and this is second. And this pregnancy, as we can see, that there is abnormal genitalia. There is no history of in vitro fertilization. Pregnancy was quite uneventful. No history of any drug exposure. I'm going to concentrate this case mostly on related to this diagnosis and towards abnormal sexual differentiation. So clinical finding that when I went to see this baby, it was a normal vigorous infant, small phallus, and it measured 1.8 centimeter. And there is a mid-shaft hypospadias. Bifid scrotum with palpable growths bilaterally. No other evidence of external congenital anomalies. The anus was perforated and baby already had meconium. So here is the picture of the ambiguous genitalia. of the baby that we have been discussing. There are testicle, a little bit of fluid in it on the both side, and here is the phallus and hypospadias underneath and perforated anus. It looks like a pretty good scrotal formation. So at this point, my differential diagnosis was more than likely it is a virilized female with XX karyotype, or it is under virilized male with XY karyotype, which has not been the case, mixed gonadal dysgenesis, or it could be one of those true hermaphrodite. With those differential diagnoses, we proceed with initial endocrine evaluation. Although clinically it did not suggest that this patient has CAH, but however, we did go ahead and do the 17-hydroxyprogesterone, which was 101 nanogram per dl. Testosterone was adequate, 76. So is the dihydrotestosterone. 11-deoxycortisol was within normal range. FSH, LH, and thyroid function was appropriate for the age. So we went to the radiological evaluation, and the radiological shows normal size kidney and adrenal gland. Pelvic sonogram shows no uterus or no suggestion of ovary. So there is no uterus or ovary found. Scrotal sonogram clearly verified our finding. The baby had two gonads, both appears to be testes, with small bilateral hydrocele. And the karyotype is the one who is completely throws us off balance. And it looks like that you could see 2x. Clearly, that was not something we were expecting. And not having 2x and have external evidence of a male infant, we continue to do further study. At this point, our genetic department was intimately involved. They were consulted, and I am thankful to Chief of Genetics Dr. Dave Rigdon and Dr. Mike McClellan, who in the genetic department helped me to solve this problem. So initial genetic evaluation, as we saw already, it is a 46XX. Then we do the amylogenin studies, which only reveal X sequence. So I'm going to talk a little bit about what is amylogenin. I don't think there are a lot of people who are very familiar with this. It's actually a low molecular weight protein found in developing animal tooth enamel. And this is used with PCR for sex determination, and it has been used in forensic as well as anthropology. Called subject when they are looking for trying to determine the sex of the patient or the person. So what normally would show in PCR, if the patient is female, has XX karyotype, will show one solid band on agar gel medium. And if the chromosome is XY, male will show two bands. So female will show one band and the male will show two bands. Our genetic department was not convinced by that study, so continued to do the further genetic evaluation. And this time, a MG study, or evolutionary studies were done with a long exposure to see whether any evidence or suggestion of Y sequence. PCR also done, however, was positive for SRY sequence. Was not making much sense, so we tried to see what we are really dealing with. Okay, so normally this is a amylogenic, this is female, and two band is male. Okay, and the patient, our patient had this one band. Okay. And the female will have one band, the male will have two band. Our patient has also one band. Sorry, that confusion. So this is one band. This is our patient. This is a female, and this is a female. Also, this is what our patient is. So, fish study with the whole chromosome band for one alpha satellite, DYZ1, DYZ3. These are the sequence of the chromosome, and they are used to hunt for Y chromosome. And important thing is, this is very specific for Y, and it will find if there is any remnant of Y chromosome or dearrangement, it will locate them. So this test was done for hunt for Y chromosome, and clearly it did show the evidence or suggestion of Y chromosome in some cells. The final karyotype, therefore, which I won't be able to show you, the 4 out of 22 cells were 46XY, and rest of them are 46XX. So we also did the parents' karyotype, which was normal and appropriate for the sex. And this is our study, fish with alpha classical pen probe, and here is the suggestion of Y chromosome. And then fish with Y pen probe also clearly shows the evidence of Y positive Y chromosome right here. So now, with this finding, our thought process changed, and the differential diagnosis at this point was mixed gonadal dysgenesis or true hermaphroditism, or a very rare case of chimerism, complete chimerism or tetragametic chimerism with 46 XXXY chromosome. Just for the fellows or people to refresh some of our audience memory, these are the salient point one should remember, and if you remember these, then you actually do very well in terms of figuring out mixed gonadal dysgenesis with the other differential diagnosis. So in mixed gonadal dysgenesis, the karyotype is 45X or 40/46X. The various spectrum of genital abnormalities from almost normal female genitalia or only to clitoromegaly, that could be microphallus, hypospadias, and rarely some features of Turner syndrome are possible. The gonad generally is a well-formed testis, and there is one side of the gonad is a well-formed testis, and another side is a straight gonad present. So this is basically a short version of mixed gonadal dysgenesis. So what is true hermaphroditism? Well, the karyotype again 45XX, about 75% of the cases. It could be 46X, 46XY, and the mosaic. So there are various type of karyotype is possible. External genitalia is variable and often asymmetric finding. The gonad is an ovotestis or testis. The gonad could be ovotestis or testis. The diagnosis is made by the biopsy, and it should show the presence of both testicular and the ovarian tissue. In other words, I think this is the salient point. In order to make a diagnosis of true hermaphroditism, one needs to show the presence of both testicular and ovarian tissue. Okay, now we come to a little bit further diagnosis to see the functional integrity of those testicles. So at this time we did the HCG stimulation test on the baby. The basal testosterone level was 30 nanogram. Post HCG was 330, which is more than 10 times, and which is a reasonable and good response. On the other hand, the dihydrotestosterone response was also very adequate. So this baby's testicle is producing enough male hormone after stimulation. Also did the testicular biopsy from both sides. Both sides of the testicular biopsy showed only testicular tissue. No suggestion of any other tissue, only testicular tissue. And at this time, our team, together with endocrine, neonatology, chromosome, and sitting with the parents, we assigned this baby as male sex. But we got our biggest surprise and confirmation of our diagnosis in about 6-month follow-up. When the baby came for 6-month follow-up, baby is doing well, growing normally, and only significant finding is the differential skin pigmentation noted, and which is a very interesting finding in case of chimer. Okay, let's go and see the picture. And as you can see, this skin is dark, this is dark, and this is much fair. On this side is dark. So at this point, we did DNA study of the serum, and the DNA study from the skin did not match. So these are two different sequences. So there was no matching of DNA sequence in the blood and the skin. So diagnosis of chimerism was made on the clinical finding and as well as DNA skin analysis, and again the karyotype. Now talk a little bit about chimerism. So this is a study that was done by Dr. Anderson in Berkeley, California, and the meat gives. This is a mixture of goat and sheep, and this part is sheep skin, face and the ear is goat, and so there is a difference. Clearly you see this. Actually, chimerism in animal is not that uncommon. It is seen in animal, but in man, human being, is very rare. About 1 in 100 case report, but there could be a little bit more. But however, no question that an endocrinologist or genetics who has gone through the practice of lifetime, even in a big medical center, may not see one. So what is a chimera? In Greek mythology, chimera is a fire-breathing monster or dragon, has a head of a lion, a body of a goat, and tail of a snake, serpentine. Here. So right now, at this point, I like to discuss these two differential diagnoses, which is more important to differentiate this. What is mosaic? And what is the difference between mosaic and chimer? Well, mosaicism, the two-cell line derived from single zygote. Two-cell line derived from single zygote. One normal cell line and one with chromosomal aberration. And the aberration occurs after fertilization. The very good example is Turner mosaics. And mosaicism is not uncommon. Chimer is when the mixture of cells from two separate zygotes. Mixture of the cell come from two separate zygotes. It could be early fusion of fraternal twin zygote with 46X and 46XY, or a double fertilization of an egg and a polar body. The individual with a intermingled cell line. It is beyond my presentation to discuss more about chimer, but it is very easily, it is written in many of the textbook, and especially the genetic textbook, and those who want to get further diagnosis and further knowledge about this, and I would refer to that. And as I said, it's very uncommon in human. It's about 1 in 100, but not in animal world. A true hermaphroditism may result from the true body chimer, which is getting a little bit more complex. And it does appear that in vitro fertilization, babies has a higher risk of developing chimer than the normal conception. Now, I like to conclude with this two, one publication and another is documentary. Those who are interested, I can refer them to, this was a Karen Keegan case. It was reported by Dr. Yu and Nanny at New England Journal of Medicine, and the title was Disputed Maternity Leading to Identification of Complete or Tetragametic Chimerism. And it was published in 2002, 346 pages and volume 20. But the other one was pretty interesting, and this was a documentary case of Lydia Fairchild case. And the title was Extraordinary People, Twin Inside Me. Also, it was presented as that the patient herself said, I am my own twin, and it was in an interview in TV5 that time in Massachusetts, Boston, Massachusetts in 2006. And these are most likely available, so if somebody wants to know a little bit more about this, then that will be placed to see. And more or less, the other genetic journal has much more definition, findings, and much more details of chimer. So I think that this has been educational to you. And as I have said that in the beginning, I thought that we will be able to make the diagnosis, and I did think that it most likely going to be under virilized male. But sometimes there is a saying, all that glitters is not gold. So I learned my lesson, and I learned a lot by taking care of this baby. And this baby is doing very well now, and the phallus is growing, and in general, that everything, the diagnosis and the sex assignment was appropriate. So, as I said, that there are many endocrinologists or even genetics specialists may have gone 20, 40 years, 30, 40 years of practice and may not have seen one. And there is a called microchimerism, which is just crossing the blood from the mother side to the baby's side and baby's placenta, through the placenta from baby to mother side. This is called microchimer, and that occurs a lot. So thank you very much for listening, and I hope it has been some educational to you all, and I will hope to see you in my future lecture. Again, thank you.